Meningitis is an infection of the caverns of the brain. It is most commonly caused by bacteria, viruses, fungi, and protozoa. One type, cerebrospinal meningitis, is caused by Neisseria meningitidis, and is very common and usually occurs in epidemics during the harmattan season. The presentation may sometimes be confused with cerebral malaria. Meningitis is a medical emergency. Failure to recognize and adequately manage meningitis results in serious combinations. Inform regional and district health authorities immediately in epidemic meningitis. Causes are bacterial from Neisseria meningitidis, Streptococcus pneumonia, Haemophilus influenza, Mycobacterium tuberculosis, Staphylococcus aureus, and Escherichia coli. It's in neonates. So it could be from viruses, for example, herpes virus, and protozoa, for example, toxoplasma in HIV/AIDS, fungi, for example, in Cryptococcus neoformans. The symptoms for adults and children more than 5 years are fever, neck pains, severe headaches, photophobia, change in behavior, convulsions, and vomiting. In children less than 1 year are fever, irritability, refusal to eat, poor sucking, vomiting, drowsiness, and weak cry, and focal or generalized convulsions after which the child is sleepy, also lethargy, bulging fontanelle. So the signs that are usually elicited for adults and children more than 5 years are fever, neck stiffness, positive Kennex sign, altered consciousness, and coma. In children less than 1 year, neck retraction, presence or absence of neck stiffness, presence or absence of fever, bulging fontanelle, coma, hypotonia and hypertonia, and also convulsions. Investigations: FBC, rapid diagnostic test to exclude cerebral malaria, and blood film for malaria parasites to exclude cerebral malaria also, and lumbar puncture only after excluding raised intracranial pressure, blood culture and sensitivity. So to identify and eradicate the causative organisms to prevent complications. So these are their treatment objectives, and to prevent spread to contacts, to maintain good nutrition. Non-pharmacological treatment, tepid sponging, keep the airway clear, nasogastric tube feeding if applicable. So pharmacological treatment, bacterial meningitis, first line treatment, you give ceftriaxone, IV or deep IM in adults 2 to 4 grams daily for 7 to 10 days. In children more than 12 years, 2 to 4 grams daily for 7 to 10 days. Less than 12 years, 50 to 80 milligrams per kilogram for 10 to 14 days. Neonates, 20 to 50 milligrams per kilogram once daily for 21 days. And then vancomycin IV in adults, 15 milligrams per kilogram 12 hourly for 7 to 10 days. In children more than 12 years, 15 milligrams per kilogram 12 hourly for 7 to 10 days. 2 to 12 years, 15 milligrams per kilogram 12 hourly for 7 to 10 days. 1 month to 2 years, 50 milligrams per kilogram 8 hourly for 10 to 14 days. Less than 1 month is not recommended. Or you can give benzyl penicillin IV. Adults 4 MU 4 hourly for 14 days. In children 0.2 MU per kilogram 6 hourly for 14 days. And chloramphenicol IV in adults 1 gram 6 hourly for 14 days. In children 25 milligrams per kilogram 6 hourly for 14 days. And this must be subsequently changed to oral therapy with significant clinical improvement. Or chloramphenicol IM, oily preparation in adults 10 milligrams per kilogram as a single dose. In children, 100 milligrams per kilogram as a single dose. It's very recommended for children below 2 months, and also for pregnant women and lactating mothers. For penicillin allergy, give clindamycin IV. In adults, 600 to 900 milligrams 8 hourly for 14 days. In children, 13 milligrams per kilogram 8 hourly for 14 days. And chloramphenicol IV in adults, 1 gram 6 hourly for 14 days. In children, 25 milligrams per kilogram 6 hourly for 14 days. Second line treatments, cefotaxime IV. Adults, 2 grams 6 hourly for 7 days. In children more than 12 years old, body weight more than 50 kilograms, 2 grams 6 hourly. Less than 12 years or body weight less than 50 kilograms, give 50 milligrams per kilogram 6 hourly. And vancomycin IV in adults, 15 milligrams per kilogram 12 hourly for 7 to 10 days. In children more than 12 years, give 15 milligrams per kilogram 12 hourly for 7 to 10 days. In 2 to 12 years, give 15 milligrams per kilogram 12 hourly for 7 to 10 days. 1 month to 2 years, give 15 milligrams per kilogram 8 hourly for 10 to 14 days. Less than 1 month is not recommended. So prophylaxis for CMS, that is cerebrospinal meningitis. Prophylactic treatment is recommended for patients 2 days prior to discharge, and also for their close contacts. So ciprofloxacin oral in adults, 500 milligrams as a single dose. You avoid in pregnancy. In children 5 to 12 years, 250 milligrams as a single dose. Or ceftriaxone IM in adults, 250 milligrams as a single dose. In children less than 12 years, 125 milligrams as a single dose. The role of steroids. Dexamethasone, started together with the first dose of the appropriate antibiotic, has been found to lead to major reduction in hearing loss and death in both children and adults. So dexamethasone should be given with caution. It's normally given IV 4 to 10 milligrams 6 hourly for 5 to 7 days. So it actually helps in reduction in death and also hearing loss in both children and adults. So it's usually dexamethasone is recommended. The referral criteria: refer all patients not responding to treatment within the first 48 hours to for specialist care. And let's quickly recap the treatment options. So summary of treatment options for bacterial meningitis. Age less than 50 years. Pathogens are meningococcus, pneumococcus, Haemophilus influenza. First line empirical treatment: ceftriaxone and vancomycin. Alternative specialist care: cefotaxime, meropenem, and fluoroquinolones. There's more than 50 years. Pathogens are pneumococcus, listeria, gram-negative bacilli. First line empirical treatment: ceftriaxone, ampicillin, and vancomycin. Alternative specialist care is fluoroquinolone. Hospital acquired pathogens are staphylococci, gram-negative bacilli, pneumococcus, pseudomonas. First line empirical treatment: ceftazidime with or without gentamicin. An alternative specialist care is meropenem and vancomycin.